Our third speaker is Dr. Shazeea Mohamed Ali, who has graduated with a Master's in Bioethics and is a consultant geriatrician, general physician, and director of training at Austin Health. Dr. Mohamed Ali is also the IMA Victoria Vice President. She will address caring for our respected elders in the month of Ramadan.
Right, wonderful. Bismillahirrahmanirrahim. Thank you to everyone for being here today to really listen to us all and allow me to talk about frailty and the older adult. I want to start by saying that everything good is from Allah and any mistakes are from me. Everything that I say here obviously is general guidance, and any individuals need individual care. That's especially important if there are any non-healthcare professionals who are listening tonight. The other thing I want to acknowledge is that our model of medicine assumes only a metaphysical component, and we cannot measure the effect that spirituality has on our physical health. So I remember last year we weren't even in full summer, and I found fasting incredibly difficult. And when I mentioned this to a friend of mine, she said, "Isn't it, all of us who are healthy, isn't it just by the will of Allah that we are fasting anyway?" So much more for people who do have medical conditions who are trying to fast. This is just an overview of what I'm going to talk about. So I will introduce you, I guess, to the Bima Ramadan Compendium, which our previous speaker brought up as well, and in particular, their risk stratification. I will introduce the concept of frailty, and then I'll try to put those two together and explain what it means for fasting in a frail older adult. Just as a means of a recap, we've heard about the Quranic verse in the Hadith about people who are exempt from fasting. So the actual verses in the Hadith are not explicit in what conditions need to be met to exempt people from fasting, but the scholars have devised, these three things. So your condition worsens, your recovery is significantly slowed down by fasting, or you're unable to perform normal and important daily chores. They also add things like pain, which I think is important. If you are if you broke your bone or something and you have sort of severe pain from that and you need to have regular analgesia during the day, that could exempt you from fasting as well. So the first section of what I'm going to talk about is the British Islamic Medical Association Ramadan Compendium. So this was put together in 2020, sort of post-COVID, and updated in 2023. It's available for free as a PDF document online, and I encourage everyone to have a look at it. It covers most medical conditions and defines for each medical condition what's very high risk, what's high risk, and what is low or moderate risk. And then has the relevant recommendations with regards to fasting. So very high risk, do not fast. High risk, they should not fast, but perhaps you can still try to make some changes here and there to help them fulfill their religious requirements. And if they're low or moderate risk, then review their medications and they should be able to continue fasting. So I've given you some examples here. So I've put up the guidelines for cardiovascular disease, respiratory disease, and chronic kidney disease, and it's probably not projecting very well, but for an example, someone with a left ejection fraction of less than 35%, so quite significant heart failure, is considered high risk and shouldn't fast. However, someone with stable hypertension is low risk and able to fast, and you might just move their blood pressure medication around or monitor their blood pressure and stop their blood pressure medication for the duration of Ramadan. Now, obviously, individual medical societies will have their own recommendations, as our two previous speakers have talked about. But I found this one really quite good to get an overview of everything in one go. And it's sort of good for me as a general physician because I practice generally. And I would imagine it's good for general practitioners as well. And will allow us to at least figure out who is in the low and moderate risk. And anyone who is in the high or very high risk, we can refer on to someone who is specialized in that area. So what the guidelines have not yet incorporated is the concept of frailty. So I'm a geriatrician. I see old, frail people all the time. And we have noticed that despite similar numbers, so all your hard numbers are the same between one patient to another, there are some types of patients who do worse than others. They spend longer in hospital, they're at higher risk of delirium. We understood this for a long time, but it was really vague. Like we knew if someone was elderly and and more frail, we would be less strict with their blood sugar targets or their blood pressure targets, for example. But we finally sort of come down to this syndrome, and we've now identified frailty as another factor that greatly influences mortality, morbidity, and quality of life. So frailty is defined as a state of vulnerability characterized by a loss of reserve across multiple physiological systems. And it's put simply, someone who is frail is less able to bounce back after a stressor event. So something minor like a urine infection or influenza will have a longer period for them to recover. And then obviously more serious events like, if they had an acute coronary syndrome or a fractured hip, they can often have really quite dire outcomes from that. More than 50% of Australians over the age of 65 are frail or pre-frail. So there's about 20% of people who are already in that frail group and another 30% who are at risk of frailty. There are many ways to measure frailty, and there's a number of tools that are used. And generally, we find that the tools are better. They're better at picking people who are frail rather than you just asking me to look at someone and guessing if they're frail or not. I've used here the Rockwood Clinical Frailty Scale, as it's got a nice pictorial representation. People who are more fit and robust have a lower number on the scale, and the higher the number, the more frail you are. 4 and 5 is where we try to target interventions to prevent frailty or to reverse frailty or to slow down frailty. When we're thinking about who is frail, what we're really looking out for is unintentional weight loss, unexplained fatigue, low physical activity, loss of strength, and slow walking speed. And at this point in time, we are trialing different interventions to see how we can prevent frailty or reverse frailty. A lot of them have to do with comprehensive geriatric assessments, exercise programs, nutritional advice and supplementation, reducing polypharmacy, and sort of looking at people's function and social situations to try to safety net around them a lot better. Now, why is frailty important? So what frailty does is that it is a risk amplifier. So as I mentioned, patients with similar hard numbers, but with different levels of frailty can have different clinical outcomes. Frailty also modifies your decision threshold. So again, same numbers, if someone is robust, you might elect to go with more aggressive management compared to someone who is frail, where you'd actually start to think about conservative management, symptom control, perhaps even palliative care. So an example here is implanting an implantable defibrillator. So, we usually use the LVEF of, I can't remember what the number is now, it's probably 20 or 15 or something like 25. But, if you had someone who is otherwise really quite fit, not losing weight, able to carry out their activities of daily living, you'd want to give them the ICD. And in someone else who is requiring a lot of assistance physically, losing weight despite trying to eat as best as they can, you might review that decision. Frailty is a competing risk. So it's trying to challenge the idea that all I have to do is put people on disease-modifying treatments, and that's going to fix all of their problems. You might actually find that if you put people on all of the disease-modifying treatments, you might actually create more problems. So considering frailty in your patient while you're trying to do the best by clinical practice guidelines allows you to make sure you're not causing harm at the same time. Frailty helps you to decide what to do next. So as I've given in the previous examples here, it doesn't tell you who is more sick, but it does sort of calibrate what you should do next and calibrate what the predictions here might be. So to illustrate this example, I've got two very similar patients, and they're very similar on purpose. The first is a 75-year-old female who's home with her husband. She has well-controlled hypertension on amlodipine. She helps to look after her grandkids after school. And on the other side, we have a 77-year-old male who's widowed and lives alone. He also has well-controlled hypertension on amlodipine. He mostly stays at home as he's not very social. He's lost confidence when he's out of the house by himself. And he wasn't eating very well, as many of our older men do when they lose their wives. So he was losing weight, and his kids started sending frozen meals. Now, despite both of them being of a very similar age, they have the same medical condition on the same medication, you would intuitively realize that you're not going to risk stratify these two patients in exactly the same way. So how do we apply this to Ramadan? So the first question that I would ask is, so what does the evidence say? So there's one study on assessing frailty and outcomes in primary care, and this was done in patients with diabetes. This was a sample size, not a bad sample size, really, about 200 people in Abu Dhabi. And they identified that frailty increased your odds ratio of 1.5 for adverse outcomes. Now, those adverse outcomes were really driven by infection and hypo and hyperglycemia, and then sort of single digit other things like stroke and cardiac events. I think there was one on medication complications. However, the follow-up period was short. So they were only looking at the Ramadan period and then immediately post-Ramadan period. It didn't measure weight loss, hospitalizations, quality of life. It didn't measure whether someone felt dizzy during the day, whether they decided to skip taking their blood pressure tablet because they didn't quite feel very great. And we can imagine that all those things would happen as well. So how do we then operate if the evidence is not very clear? This is sort of the specialty in geriatrics because people don't really do studies on the very elderly or the very frail. And I guess we come back to the first principles of geriatrics, which is to think holistically and approach the individual with more than numbers in mind. So this to me means incorporating frailty into shared decision-making, thinking about and asking about the person's values, preferences, and circumstances, which hopefully if we have Muslim patients coming to us, we have the language to be able to explore that. Exploring their understanding of the health and of the fiqh. It's unfortunately not surprising, but there's a lot of Muslim patients out there who don't actually understand the fiqh and don't understand that there are exemptions from them. And then working through, with the medical guidelines, what the benefits and risks of fasting will be. Now, it's important to remember that most patients will want to fast, and most doctors will probably tell them not to fast. And so hopefully we can come to a middle ground somewhere. And the evidence actually shows, at least in diabetics, that most will want to fast as long as their previous experiences of fasting have been positive. Or if the experience has been somewhat mixed, they're still quite determined to fast. And only really when their experience becomes negative will they take the exemption to fast. And I think we can all relate to this. How many of us have had a cold and will push through with the fasting, either because we feel guilty or we don't really want to have to make it up later. So it's important to understand where patients are coming from, but also where we as doctors are coming from, even as we are Muslim doctors. And there are obviously ways in which for us to modify fasting. So can we try alternate day fasts? Can we not fast in summer and instead, make up the fasts in winter? I think it's really important that in many of our, I am actually going to say in many of our even low risk patients and in ourselves, we think about what nutrition looks like. And in those of us who need extra help, we enlist the professional services of a dietitian to help us meal plan for the entire month. Do some of our more socially isolated patients need their families on board as well to provide perhaps the nutritional support, but also the social support and the medical safety netting? And then is there an ability to check in during the month to see what the experience of fasting is like? And whether we need to change the risk-benefit ratio and start telling them that, I think we're actually heading down the path of getting to a place where things are going to be irreversible in the future. So that was just sort of a blitz through a bit of frailty and what it means for the older person. I didn't touch on dementia, which is another big area in which I talked about. And sort of really, I think it's in the Ramadan compendium really beautifully. They mentioned that if someone doesn't even know that it's Ramadan, they don't know if they've eaten, they don't know if they haven't eaten, then obviously they're exempt from fasting. Allah has lifted that from them. For some of them who sort of have Alzheimer's and they know that they're meant to fast, but they forget that they're fasting and they have something to eat. Perhaps it's better that we just don't say anything and just allow them to take part in the month as they can, and Allah obviously will reward them according to their effort. These were some of the references that I used, and I just wanted to plug that I come across a lot of clinicians who will say, oh, I don't know what to tell my patients when they come to me with fasting. And I think it's really important to remember that as doctors and as Muslim doctors, we have an amana to our community. And it's actually not very hard to start somewhere very simple with the medical fiqh. People who are much, much smarter than me have laid out what all the medical guidelines is. It really is just a matter of us being able to access that information. And I highly recommend the Fiqh of Medicine course that a few of us have done over the years. And it's run online by the Al-Balagh Academy and actually taught by a scholar and GP who works for the NHS in the UK. Thank you very much. Jazakallah khair.
Jazakallah khair, sister. That was an amazing talk, and thank you for illustrating the importance of identifying and addressing frailty in our respected elderly community. And those references were amazing. I think, look, the BEMA Ramadan compendium is absolutely excellent and really should be shared with our non-Muslim colleagues just to improve their understanding and clinical advice that they may be giving to their patients as well.